And it's very remediable, as I said. There are drugs that we can give that prevent the progression of cardiomyopathy and stabilize things. Okay, another common problem in mitochondrial disease is swallowing problems, or medical term is dysphagia. Again, there may be quite a number of people involved. Key people in this are perhaps a speech and language therapist, as well as neurology. And I see Shamima sitting in the front row here, so I better say metabolic as well. But the important thing is that people are thinking about swallowing. And thinking about it every time the patient comes to clinic, because it's so important in terms of nutrition. It's important in terms of risk of aspiration and pneumonia. Swallowing is an extraordinarily complex procedure that we do hundreds, if not thousands of times every day without ever thinking about it. And it's a coordinated action of a whole host of different muscles that occur, as I say, without us consciously thinking about it, and within a split second. And if that doesn't work properly, things can go down the wrong way. They can go into the lungs. They can cause an aspiration pneumonia. Aspiration pneumonia can have metabolic consequences in terms of the extra demand that that's placing on the body to fight that kind of infection. And children and adults have ended up on intensive care units as a result of aspiration pneumonias and things going down the wrong way. So, very important in terms of preventing progression of disease, in terms of ensuring adequate nutrition. So it's largely assessed clinically, but there are also other techniques that are possible. I thought I'd put one on there called a video fluoroscopy, where patients are given a little bit of radioactive barium to swallow, and you can then see the barium going down and follow the different phases of the swallow. And that's usually done in conjunction with a radiologist and a speech and language therapist. And then dietetic review, simple things like altering the consistency of the food that you're trying to eat. Eating is an important social aspect to it. It gives children and adults a lot of pleasure in terms of being able to eat the things that they want to eat. But it may be that they can continue to eat to supplement what they're being given via PEG, and to eat for enjoyment rather than to have the pressure of getting the calories they need for nutrition. But it's important then that there's good advice about the type of food that they're eating. And then what can we do about it? Well, we could put in a PEG or a nasogastric tube feeding, and many of you will be very familiar with the insertion of PEGs. Okay, another thing that we can monitor for, detect and treat is diabetes mellitus, and there are other hormone problems as well that we can give replacement hormones for. People involved in this will be mito specialists, endocrinologists, and general pediatrics. Again, should be considering this at every clinic review. It is more common in some forms of mitochondrial disease, so they may be much higher up the agenda of the clinician caring for you or your child. And it is more common in some forms of mitochondrial disease, so Kearns-Sayre syndrome due to large-scale deletions of mitochondrial DNA or duplications. And this particular point mutation here, 3243A to G, which is one of the commonest mitochondrial DNA point mutations. So we should have a very low threshold for checking for this. Again, simple dietary measures can help prevent progression to diabetes, can help once diabetes is diagnosed, and those are balancing carbohydrates, proteins, and fats in the diet. Treating with tablets, glimepiride. There's a suggestion that we should perhaps avoid metformin because of a theoretical risk of making acidosis worse in patients with mitochondrial disease. But there are many people who've been treated with metformin long before they've had their diagnosis of mitochondrial disease because they've developed the diabetes as one of the heralding symptoms of a mitochondrial disease, and they've done fine. Insulin, it seems mitochondrial diabetes is not type 1 or type 2, but really type 1.5. And people do progress to requiring insulin often quite quickly and quicker than you might expect. if this was just a simple resistance form of diabetes. And then other endocrine problems, thyroid and adrenal glands can be involved in mitochondrial disease, and so they secrete thyroxine and cortisol, and those can be replaced orally if they're detected. Again, can be quite insidious, particularly hypothyroidism, can come on very gradually, worsening of constipation, feeling the cold, a general dulling of interaction. So it can be very subtle signs sometimes. Another thing that we monitor is vision, very often involved in mitochondrial disease. And there are two components to this. There's the eye itself, and there's the brain. And the eye itself can be involved in mitochondrial disease in many different ways. The cornea, the lens, the muscles around the eyes can be affected, the retina at the back where the light shines onto, and the optic nerve itself, which conducts the signal from the retina right to the back of the brain. And the back of the brain and the occiput is a common site of involvement in mitochondrial disease. And we call that cortical visual impairment, and some of you may have heard that term. But that's essentially a brain, it's essentially a brain form of blindness. Whereas other forms of visual impairment affect the eye itself. So again, who should be involved in monitoring? Well, an ophthalmologist, someone who can look at the back of the eyes in great detail, may require drops into the eyes to dilate up the pupils, and then they have a look with some specialist equipment at the back of the eyes, take some photographs, and even do some neurophysiological testing of the eye. Young children tend not to self-report problems with their eyes, and even adults sometimes don't report problems with their visual fields, particularly if that involves the peripheral vision, because peripheral vision can be lost for quite some time before people recognize it as a fault. Again, certain forms of mitochondrial disease are more likely to involve the eye, so Leber's hereditary optic neuropathy, Leigh syndrome, Alpers, often that's a cortical visual impairment, NARP and 3243, where again the retina of the eye is involved. And of course there are things like visual aids, Braille, stick training, adaptations that can be made to the classroom, all sorts of things that can be put in place to help people with visual impairment. And then, of course, hearing. That was why I put up a picture of Prince Charles. Not that I'm a royalist or a real fan. Again, fairly straightforward testing that we would encourage to be done at baseline. Again, perhaps with some particular mutations are associated with hearing loss, 3243 again, but 1555 is another point mutation in mitochondrial DNA that causes this, and there are a number of others that are associated. You can see the girl in this picture has some headphones on. She's asked to press a button when she hears a sound. The sound's played at different frequencies in one ear, the other ear, or both ears at the same time. And you get a chart like this, which tells us about the hearing in each ear, the left and right. Again, this is quite specialist testing. How often would we recommend repeating it? I'd say probably 3 to 5 yearly if the first test is normal, but that might be sooner with very specific mutations. Or particularly if someone starts developing symptoms of hearing loss. And again, we'd want some speech and language therapy input, largely around encouraging other forms of communication in people who are severely deaf, and that would include signing and communication devices. There are all sorts of devices available now for people with hearing impairment. There's of course hearing aids, and certainly many of our adult patients report that the hearing aids also amplify background noise, and so that can complicate problems because it doesn't actually resolve the problem, it just makes everything much louder. And so some patients have found benefit with these sort of directable microphones, which actually just pick up the voice that you're wanting to listen to rather than the background noise. And what's just gone slightly off screen there is the cochlear implant. or part of it. This is the bit that sits around the ear. All of this monitoring sounds like quite a lot of work, doesn't it? We've been involved with a team from Metapad to try and simplify some of this monitoring process. And we're going to be enrolling some patients on the first phase of this at the beginning of August. And basically this is a phone app-based system that tries to bring all of this data together, where patients are asked to self-record symptoms and complete questionnaires on their phone. That allows communication with the clinicians looking after those individuals. You can see here's a little bit of text messaging going on. We will be refining exactly how that's going to work with Metapad when we've got the first 10 patients on board. And it's a space to watch, but potentially lots of the things I've talked about could be recorded by patients. Record bits of video if it's a fit that's going on and you're not sure whether it's an epileptic fit or something else, dystonia. We can record the frequency of seizures. You can record the frequency of bowel opening and constipation. Diabetes levels, you can see monitoring be really helpful in that. And it's not just ourselves in Newcastle, but colleagues in London and guys are also involved with Metapad in doing this. So I've said any questions here. I don't really